Again, thanks for having me. The MIROR program overall tested the idea that because some patients don't respond to pegloticase, they develop anti-drug antibodies. If you add methotrexate, you can prevent that immune response from limiting the course of therapy that patients can get. And the results were extremely successful, right? The group randomized to get methotrexate had a 71% response rate at 6 months compared to just 39% in the patients that got placebo instead of methotrexate. And those results were durable, going out to roughly 60 versus 30% response rate at 12 months. So the concept of remission has kind of not been fleshed out in gout as much as we'd like. There are multiple types of remission in rheumatoid arthritis and lupus and even, psoriatic arthritis, but we don't have a widely accepted definition of remission in gout. And part of this is maybe we didn't have the data sets to look at it. A lot of the oral therapies kind of modestly lower uric acid. And so in a 6 to 12 month time period, that might not be enough urate lowering to see other benefits. So with the MIRROR study, we had 12 months of data and we just pooled responders together. We did not believe that methotrexate would have any impact on the actual disease measures in gout. It was just going to help more patients be responders to pegloticase. So we combined responders, methotrexate or placebo, and looked at everyone. Right, great question. So we had to kind of build out what the remission criteria would look like. And we knew we wanted to have low uric acid level, tophi improvement, gout flares improvement. The flares are probably what matters to patients the most. So that's going to be anywhere in criteria. But then we also added things like, HAC pain and physician global assessment and swollen joint count just to round out that experience a little bit. And so what we found was that, at the 12-month period, 47% of patients met these fairly strict criteria for gout. So if you're a responder to pegloticase and you can make it 12 months on therapy, which is a good length for most patients, you're not just going to have low uric acid, you're going to have tophi improvement and patient-reported outcomes improvement and fewer gout flares. And so what I think that kind of means is that when we talk to our patients, we often just say, this is your gout medicine, take it, and I'll see you in 3 months or 6 months. And the patients kind of are left thinking, what am I getting out of this? And a lot of those medicines might not lower the uric acid enough in the doses used to help, but with the uricase enzyme, there really isn't much in the way of dosing. You're on the medicine, and if you're a responder, your uric acid level will be 0. And so if we can sort of describe to our patients, I want you to take this medicine at least 6 months, maybe 12 months, and we're going to lower your uric acid. But as part of that, we can expect to see these other benefits. Now, not all of these are in the label, but a lot of the ones that aren't in the label are actually most important to patients. Pain and flares and swollen joints. These things matter and they affect how the patients function. And so I think having that conversation that not only is remission definable, it's achievable in a really manageable time frame as well, if you truly lower the uric acid enough. Sure. So we really had a good time presenting this at EULAR in Vienna just last week. And I'm pleased to report we were not the only project looking at remission in gout. So this topic is definitely gaining momentum. We got some nice feedback from some of our colleagues in the field. And I think before we take this current project to full manuscript, we're going to look at other variations of gout remission criteria and see how it performed. If anything, what we're going to do is simplify the criteria, because before something goes wide, you want to make sure that it's easily adoptable and everyone can understand it. And so, remission criteria as simple as low uric acid, resolution of tophi, and no flares may get you most of the way. And so we've had an even higher percentage of patients that meet those because you're now removing things that might have kept them from reaching remission. Really, the other things that we're looking at for a medicine like pegloticase are more logistic oriented, right? It's an every 2-week infusion. You have to infuse over 120 minutes. If we can simplify some of those things and make it easier for patients so they can fit it into their busy lives, then we've definitely further improved patient care in the experience. So our findings are, I think, an important contribution to this discussion on remission in gout. And what we really need from rheumatology especially is to define what we're going for, right? The gout guidelines from 2020 specifically recommend against falling prey to what they call gouty inertia, which is where someone's kind of close. Their uric acid level might be kind of where you want it, but it's not fully there. And we just kind of shrug and say, well, you're pretty close. Let's check it again in 3 months. That's when care is focused on just that number. And so one incremental step of improving that is treat to target, right? You've got to get to the target. And if it's not working, then you have to do more or do something else. What we add with a really robust conversation on remission is it's not just the target, it's what symptoms the patient is experiencing. And it opens up the possibility of just asking the patient, what matters to you the most with your gout? Let's improve that. And so as we kind of have more entries into the field discussing remission, the ultimate goal would be to get agreement on something that can then be put out there and is simple, easy to understand, easy to follow. And then you kind of go from just gouty inertia to treat to target to treat to remission. And all of these, in my opinion, are incremental improvements that just make lives better for these uncontrolled gout patients. Just again, that gout continues to be mislabeled as a lifestyle disease. We know much more than ever it's a genetic and renal disease with lifestyle components. But lifestyle is never going to be the answer to treat gout, even though it might contribute to some people getting gout. And so recognizing this as a inflammatory disease that warrants aggressive therapy that'll improve patient lives, and I think our study on remission goes quite a long way to putting forward the discussion that this is how we should approach this. This is the goal.